Which would be your answer to these questions? Although your dosimetry plan fulfills the dosimetry constraints, could it be better optimized? What quality level do you have to reach in your dosimetry plans? Would it be possible to increase the quality of this particular dosimetry? The answer to all these questions necessarily implies the definition of the quality of a dosimetry, but this can only be done once a certain context has been established. Which accelerator have you used? What techniques? 3D, VMAT? What fractionation? And so on. And if this context is established, it is really difficult to define the quality of a dosimetry, especially if the aim is to define it in an objective and even more, a quantitative way. The ideal dosimetry treatment would deliver 100% of the prescribed dose to the tumor and 0% to the organs at risk. We tend to this top quality utopia when instrumentation techniques, location of the tumor, and patient's anatomy, among other things, work together in our favor. The reality is an objective assessment of the quality of a dosimetry involves different definitions of quality for different situations. So the questions to be answered is, in your situation, with your technology, your technique, this specific patient, which is the highest quality level you can achieve in your dosimetry. In our service, we have established a way of evaluating the quality of dosimetry by comparison with the reference established from a set of analog dosimetries already carried out and clinically approved. With a significant number of dosimetries of each type, we define an initial reference state from which we record the most representative values of this dosimetry. For example, in the case of the prostate cancer, we register the mean values to the organs at risk and the minimum dose to the tumor and its volume. We use the averages of these values and their standard deviations to calculate with ad hoc equations, and for each structure, the quantities that will play the role of T, 50, and gamma in the logistic model, which give us the normal T-cell control probability, complication probability, and the N0 that goes to the Poisson model, which gives us the tumor control probability. By construction, these curves consider the variability between patients in terms of all the aspects that may influence the quality of a dosimetry. The generated curves are representatives of the considered dosimetries for the initial reference state and set the scenario where each single future dosimetry will have its quality evaluated. The plot gives information about the strategy to follow to improve our optimization. In this case, we better optimize the rectum and the bladder, for example. We can now compute a quality index, QE, for each dosimetry that mimics the definition of tumor control probability without complications, and that can be compared with the initial reference state. Therefore, we can perform several iterations until we reach the optimal solution for that dosimetry. Thus, the IQ becomes a tool that will facilitate the task of knowing until when it is appropriate to optimize a dosimetry based on what has been considered optimal until now. It will also allow knowing what the room for improvement is and the specific strategy to do it. Therefore, the IQ can monitor the evolution of the dosimetry quality, offering a method to control it, maintain it, and progressively tend to improve it, regardless of the personal specialist, technician, or student who has carried it out. If you like this idea and would like to implement this tool or something similar in the clinical routine in your hospital, please don't hesitate to contact me for further and more detailed information. Thank you very much.